Chairman. It's my honor and pleasure to be invited to have a presentation on phacoemulsification step by step in the next 20 minutes. I don't have any financial interest. In this presentation, we are going to summarize what's the history of phacoemulsification, patient selection, patient preparation, construction of the wounds, capsulorhexis, hydrodissection and delineation, viscodissection, nuclear fragmentation, soft hard cataract, chopping techniques, irrigation aspiration, intraocular lens implantation, and hydration of the wound. All of us are familiar with the history of the wound size in cataract surgery, starting by 12 millimeter in the intercapsular cataract extraction, then 10.5 in the extracapsular, then in Sykes with the 5.5 millimeter, then the standard phaco with foldable IOL, then the bimanual phaco of 2.2 millimeter, and lastly the microcoaxial phacoemulsification with 1.8 millimeter. Charles Kellman was the first to invent the effect of freezing on the eye, and he invented the cryo machine. And again, he was a resident in Wills Eye Hospital, and in 1967 he had a grant of for invention of a way to remove a cataract through a tiny incision, eliminating the need for hospitalization, general anesthesia, and dramatically shorten the recovery period. And he discovered the phacoemulsification. This is the prototype of the handpiece. It was very heavy. The first surgery took about 6 hours in the cadaver eye, and then the first eye was done, and the corneal edema subsided, but the power of the IOL was -14. Phacoemulsification is the most exciting innovation in cataract surgery in the 20th century, and this was introduced by Charles Kellman. For selection of patients, we have to take care of the age of the patient, the degree of nuclear opacity, and for the phaco beginners, it's preferable to start for the age between 50 and 60 years of age, and the degree of nuclear opacity between +2 and +3 nuclear opacity with a good red reflex. And of course, all cataracts should be dilated before surgery during the examination. Anterior chamber depth should be put in mind, because at the deep anterior chamber or shallow anterior chamber, the surgeon may feel some difficulty. So for the phaco beginners, we have to have a reasonable anterior chamber depth. And of course, the lens should be stable. All of us are familiar with the Locus 2 classification of the nuclear opacity, starting from grade 1 up to grade 4 nuclear opacity, or grade 5 nuclear opacity, which is the cataracta nigra. For the wound construction, the clear corneal tunnel incision is either 2-stepped incision or 3-stepped incision. This is a diagram showing that we take first an incision, just demarcation line at the site of entry, and then have a tunnel in the stroma, and then change the direction of the diamond knife or the keratome or the stainless steel keratome into the anterior chamber. This is the construction of the wound, just having incision, which is about 3 millimeter at that time, and then the diamond knife allows the short tunnel incision, which is rectangular in appearance, and then go to the anterior chamber. This is the typical and the ideal wound incision for phacoemulsification, to have a self-sealed 3-stepped incision surgery. Now, many of us are familiar with the 2-stepped incision. This is the side post, which we start with first, and then putting viscoelastic over the cornea, which helps good visualization of the cornea if there is dry eye or any mild corneal opacities. Then injecting this OVD inside the eye, and to make the pressure high. And here is the 2-stepped incision, again short tunnel, and then go inside the anterior chamber. This is the 2-stepped incision. Tunnel incisions, they don't induce any short or long-term astigmatism of clinical importance, whether the clear tunnel or clear corneal tunnel. And the very important number to put in mind is the 2.6 millimeter incision. 2.6 millimeter is the incision which is astigmatically neutral. If it is more than 2.6, it induces surgical induced astigmatism. If it is less than 2.6, it is astigmatically neutral. So the cut-off number for astigmatically neutral incision is the 2.6 millimeter. Temporal approach has many advantages, having visual recovery faster because it's away from the corneal edema, which is induced more at the wound, It has more space for the surgeon's hands. There is no eyebrow barrier. If you have sunken globe like this, it's easier to go through the temporal approach, which is easier to deal with. And it only needs a special speculum that allows the phaco handpiece to pass through the temporal approach, and it is less traumatic to the eye and more comfortable to the patient. Capsular access. The term capsular access or the term rhexis means bursting or rupture or tearing by the Greek word. And this capsular rhexis has 4 C's. It should be continuous, curvilinear, circular capsular rhexis. 4 C's. Prerequisites for capsular rhexis: you have to have some red reflex or to stain the anterior capsule, well dilated pupil, normal depth of anterior chamber, enough viscoelastics, stable lens. And adults, it's easier to start than in children. No capsular rhexis, no phacoemulsification. If you didn't do capsular rhexis, no phacoemulsification. No capsular rhexis, no phacoemulsification. There are different techniques of capsular rhexis. Prefers to prepare your insulin needle to be like SA2 instrument to allow to put it inside the eyeball. Then doing capsular rhexis with the insulin needle only. Many surgeons are familiar with this. First, magnify. This magnification is very important. Then focus on the anterior capsule and have a good red reflex. Start from the middle, having the flap. This flap all of the time should be back on the lens surface. All of the time pull from the hinge between the flap and the original capsule, and it should be in a rotating manner to create this rhexis. Be sure that it ended properly from outside to inside. Also, it could be done with the capsular rhexis forceps, which is special forceps. After taking the incision in the anterior capsule, this capsular rhexis forceps could be introduced through 2.2 millimeter. It needs some relative manipulations. The same way, it's relatively easier than the SA2. And again, as you see here, once you have the flap, the second hand acts as with the spatula. Here you hold from this point, which is the point from the base of the flap and the edge of the capsule, in a shearing force or rotatory manner. This is one of the most difficult areas behind the capsule. If you feel that it starts to go away, stop, inject viscoelastic, and again hold from the hinge between the capsule and the base and pull centripetal. You see the direction of pulling? It is centripetal to change the direction of the capsular rhexis. Again, we can do the capsular rhexis with the micro incision capsular rhexis forceps, which is very helpful, especially in the children's lenses which have very tough and elastic capsule. After having the starting capsule edge, then with the capsular rhexis forceps, you can pull again in the same direction. It's even easier and faster, and it can pass through the 2.2 millimeter incision easily with completing of the rhexis in a circular, curvilinear, continuous manner. Sometimes you start with the SA2 or with the insulin needle, but you feel that the rhexis is starting to be far away, or you are not controlling, or it is very friable rhexis with multiple edges. Here, in order to have a good rhexis, preferable to go out and have the capsular rhexis forceps, which is more controllable and easier to follow, and to do your capsular rhexis as usual in a circular manner. And this, as we said before, the spatula in the second hand, which helps completing the rhexis. If you have a radial tear, you have to change the direction to centripetal direction. Let's see what happens in a case like this. After staining with tetraphan blue, we started the rhexis in a mature cataract, and here, as you see, it was straightforward, and at this point you feel that the rhexis started to migrate out. Once start migrate out, return the flap back, inject OVDs, viscoelastic, whether cohesive or dispersive, and with the capsular rhexis forceps, see the direction. It is 180 degrees against the side of the direction of the tear. So if you have a radial tear, you have to change the direction 180 degrees. Again, you are pulling in the direction of 180 degrees against the tear, which changes the direction of the capsulorhexis, and then you can continue as usual, taking care. In some cases, if you have a hypermature cataract, you may face the Argentina flag sign, and in this case, for the beginners, our advice is to convert. But if you can complete the rhexis, you can continue phaco if you have soft nucleus. As you see here, the nucleus is very hard, it is nearly black cataract, and the capsulorhexis now is totally completed. Infantile capsule, make it very small and always centripetal. Capsular stains, we started in 1997 or 1998 with the gentian violet, which was prepared from the pharmacy, but in aqueous, not in alcohol, and autoclaved, and we used for a long time till the discovery of the trypan blue, which is less toxic to the endothelium, and methylene blue is the most toxic. And we had the research on the different types of stains, and we found that the trypan blue is the least toxic, followed by the gentian violet, and the most toxic is methylene blue. This is one of the first cases, or maybe the first case, of staining the gentian violet, and you see here that the stain is in violet, not in blue, because of the gentian violet. And of course the quality of the video is not so good because it is a very old video, but you see again that the staining of the endothelial side of the capsule, it's more staining because the cells are present on the endothelial side and not the epithelium. The capsular stains, simply, this is a patient of 35 years old with a mature cataract, and after cross-linking, and cross-linking, even if you cross-link the lens, it will become hard. As you see, we inject air, and under the air we give the trypan blue to stain the anterior capsule, and then you can wash the air with saline and then viscoelastic, and then do your rhexis. Capsulorhexis has many advantages. It allows greater manipulation of the nucleus with definite in the bag IOL. Even with posterior capsular tears, IOL could be safely implanted in the sulcus, 60% stretchable for nucleus delivery, even the extracapsular cataract extraction. So all of the time, make it 5.5 mm rhexis in all patients. There are no tags or flaps that interfere with aspiration of the lens matter, so you can deadly sure be that the lens matter is totally cleared with a minimum mechanical force on the zonules, and it keeps the posterior capsule posteriorly ballooned all of the time. The second is hydrodissection. After capsulorhexis with the BSS, as you saw, the wave that passed behind the nucleus is the hydrodissection wave. Following the hydrodissection, again, this is the wave which is seen passing behind the nucleus. Then for the hydrodelineation going in the nucleus, you may have 2 or 3 golden rings to see how small is the nucleus. And sometimes now you do the viscodissection, and sometimes with the visco we can even help in disintegrate the lens if it is soft. So the viscodissection is very helpful to have a cushion between the nucleus and the epinucleus in the posterior capsule, and even can divide the soft nucleus. Viscoelastics. Before talking about viscoelastics, the point of nuclear rotation is after doing the hydrodissection and then trying to rotate the nucleus. You see here the wave was not complete, now it's a complete wave. Trying to do hydrodelineation, trying to rotate. The rotation is a little bit difficult, but when you go out and inject viscoelastic, this viscoelastic behind the anterior capsule, and now you can rotate easily the nucleus. So viscoelastics, number one, it's very helpful in the nuclear rotation and with the viscodissection. Soft shell technique is injecting 2 types of viscoelastics, a viscocohesive and a viscodispersive. Viscocohesive like the Helon with low molecular weight and expands more on the anterior surface of the capsule. And the viscodispersive is like methyl cellulose, which protects the posterior capsule. Steve Ashinov invented the soft shell technique by putting the 2 types of the viscoelastics and then reverting them, putting the Helon or the viscocohesive in the bag and following it the viscodispersive in the over the bag during insertion of the IOL. This helps putting the IOL easily, protecting the cornea, and when you wash the OVDs, it's easily washable and rapidly getting out. Heavy viscoelastics are very valuable when you have rent in the posterior capsule. It acts as a third hand, giving this viscoelastic will eliminate and will delineate where is the tear. As you see here, the posterior capsular rent is very well seen in the center of the posterior capsule. Before inserting a phaco probe, you have to have perfect capsular access, hydrodissection, hydrodelineation, viscodissection, and rotation of the nucleus. You have to synchronize both hands, both ears, both feet, one with the microscope and one the machine, and both eyes together. There are different techniques of phacoemulsification, and then followed by aspiration, irrigation, and foldable IOLs. How to convert to phacoemulsification? You have to know your machine very well. If you are going to talk about the machine only, it may take about an hour to understand the phaco machine, but simply there are three parameters: the aspiration rate, which is calculated in cc per minute, and the vacuum power in millimeter mercury, and ultrasonic power in percentage. That's why every machine has its own ultrasonic power. Number two, you have to adjust your parameters in different stages of the procedures. You have three stages of the procedure. Stage 1 of sculpting the nucleus, or phaco 1, you need high ultrasonic power, 60 to 80%, low vacuum power, low aspiration rate. These are the basics. We're not going to talk about the ozil or the micropulse or the different types of the rotatory ultrasonic power. Here is the phaco fracture. In phaco 1, we're doing grooving with high ultrasonic power, low vacuum with a flow rate of 18 cc per minute average. After doing two grooves, which is a very deep groove till red reflex starts to appear, we have another groove, and this is the divide and conquer technique, to have a cross-like groove in the middle of the nucleus. So you divide the nucleus, which is hard, into 4 quadrants, and after doing a deep groove, you can disassemble or separate the quadrants from each other to receive the red reflex. Every quadrant is separated alone, and after separation of the 4 quadrants, now you can go to the second stage of the nuclear disassembly and getting every quadrant. But this is the divide and conquer, which takes a lot of ultrasound. It's easier to do phaco chopping, and this chopping is an easy technique that decreases the amount of the ultrasonic power, and with increased vacuum, it depends more on the vacuum than the ultrasonic power, and it has less effect on the corneal edema. The second stage, or stage of mobilization of the lens fragments, which is phaco 2, where you increase the vacuum power to up to even 400 millimeter mercury, and you work in the security zone and decrease the ultrasonic power to 30 to 40%. And here is phaco 2. After the disassembly, decrease the ultrasound, increase the vacuum with a low flow, and every quadrant is taken and occlude the phaco tip with the nuclear fragment, and after occlusion you can induce the ultrasound. So start with the occlusion with high vacuum, and after the occlusion divide it with the chopper or with your second hand into small pieces and get the lens matter out. The stage 3, or the removal of the epinucleus, or phaco 3, where you don't have any ultrasound, with high flow rate and vacuum about 125. Here is no ultrasound. You remove the epinucleus, high vacuum and high flow, so you remove the whole epinucleus and only you have the lens matter behind. Irrigation aspiration is a removal of the lens matter with like the Simcoe cannula, and even if you hold the posterior capsule, there is no problem, because holding the posterior capsule does not cut it, but pulling the posterior capsule is the thing which cuts it. Manual IOL insertion. This was again an old video with intraocular lens folded and inserted through the 3mm with the forceps, and after unfolding the IOL, it's put inside the bag, and the haptics, it was a high myope with low power IOL, putting the haptics inside the bag, and thus the surgery was finished. But it's easier now to do the equa insertion while having the irrigating solution from one side, and you insert the IOL under the BSS through the injector through 1.8 or 2mm incision, and then putting the IOL inside the bag. This will prevent the increase of the intraocular pressure after the surgery. Hydration of the wound, it's a final step which is essential to close the wounds and to make the pressure high. In conclusion, phacoemulsification has a deep learning curve. Observation, assistance, supervision are mandatory for beginners. Capsular access is the most important step in phacoemulsification, and step-by-step conversion is essential for successful surgery. Thank you very much for your attention, and if you need the presentation with all its videos, it's available on my email with my pleasure. And thanks again for all the organizing committee for allowing me to give this presentation. Thank you.